Conference will now be recorded.
Hello, everyone, and welcome to the AnCan High Risk Recurrent and Advanced Prostate Cancer video chat for Monday, September 15, 2025. I am Len Sierra. I'll be moderating today with a little help from my fellow moderators, Rick, Dr. John, and Ben, and all of you, our now well-informed attendees. As a reminder, this video chat is for informational purposes only. Nothing contained in this discussion should be construed as medical advice. We want to acknowledge and thank our sponsors, and they are Bayer, J&J, Myriad Genetics, Novartis, Telix, and Blue Earth Diagnostics. Okay, let's see. We will start then with Steve D. Steve, I don't know if you're familiar with our process here, but when you're new, you get priority attention, and I'm going to ask you a few questions about your diagnosis and prognosis and all that sort of thing. Please don't try and jump ahead of me because we want to keep things in chronological order. So, how old are you, Steve?
78.
Okay, and when were you? Where do you live, Steve?
Berkeley, California.
Okay. And when were you diagnosed?
About a year ago. I guess I had a MRI. The MRI gave some numbers and things. Then I saw the first doctor, and he said, "Okay, now we're going to have a biopsy to see about stuff." So I'm not sure exactly what you termed the starting date.
Okay, right. It doesn't have to be exact, just a general idea.
About a year ago.
Okay, and do you recall what your Gleason score was and your PSA at the time of diagnosis?
PSA was 40, Gleason 7s.
3 plus 4?
3 plus 4s, yeah. I think I had like a little partial 5 in there after the biopsy, but it's pretty much all 3.
I'm sorry, I missed the PSA. Did you say 40?
Yes, 40.
Right.
Okay, did you just say you thought you had a partial 5?
Yeah, in the biopsy there was a little smidgen of 5 that came up.
And did they give you a 4 plus 5 score in any of those?
No, it was just mentioned in passing. So it was just call it 3 plus 4.
Well, we can't, you see, because that 5 that was just mentioned in passing becomes really critical, but we can definitely get into that.
Yeah, well, there's going to be more critical stuff coming up here, so don't worry about
that. All right. Where were you first diagnosed?
This is with UCSF, University of California, San Francisco.
Right. And who was your urologist?
I have 3 urologists, one for surgery, one for medical, one for radiation.
A urologist for radiation?
Yeah, they separate the whole thing out, so it's like 3 guys are working.
Who are you? We're real familiar with them, Steve. Who are the 3 docs that are treating you?
Dr. Wong for radiation.
Yep.
Nguyen or Dr. Yin for the surgery.
Yep.
And Chofsky for the medical.
Okay.
Okay, so it sounds like you did have a prostatectomy.
Yep, that was in March.
March of 2025?
Yeah, this year.
Right, okay. And what was your post-operative PSA?
Initially, 2 months after the surgery, it was 0.995. About 10, 11 days after that, it was 1.16.
Okay, and that's a pretty quick rise after surgery. Did you? When did you have salvage radiation therapy?
Not. I'm coming to that. We're going to start radiation really soon. I was put on ADT
Yeah.
starting right after that, the PSAs. So I've been taking Orgovix and Nubequa,
Okay.
and it's been undetectable PSA for about 2 months now.
Undetectable.
Yeah,
Okay.
so below 0.015.
Okay. And yet they're still thinking about radiation.
Oh yeah, they know there's stuff there. What happened after the surgery? We did another PET scan. Did the PET scan before the surgery? I was going in, sorry, going into the surgery as a 2C, but the PET scan showed a active lymph node, right iliac lymph node, and that was due to be taken out in the surgery. It so happens that they removed 10 lymph nodes, but missed the active one. So I lost 1/3 of my lymph nodes, but we didn't get the right one. And further, there was a positive margin at the bladder neck.
Okay.
So we have a couple of sources. So then after the post-op PSAs, we did another PET scan and found that the original lymph node was still there. And plus, there was a little flicker in my sternum. So there's a bone mets.
Okay. So that little bit of 5 that you mentioned earlier on is starting to show its effects.
Yeah,
You
that
wouldn't,
could.
yeah. Have you had any genetic testing?
Yeah, there is nothing positive on the genetics, and the
You had
decipher is 0.46.
0.46. Okay. And so the germline or inherited genetics were negative, but what about
Yeah,
the somatic
yeah. All the inherited stuff was negative.
and the somatic? Did they do a biopsy on the uh, prostatectomy tissue? I mean,
Well,
did they do a genetics on it?
yeah. I'm thinking there's nothing that I remember from that, so I'm doubting that there's any positive.
Hmm.
But yeah, what they did is they got all the lymph nodes and they looked for cancerous activity, and of course there's nothing on what they took out. And so what they were hoping for was that the pre uh, pre PET scan was simply an error or something, and a false positive. But of course, it was showed up in the second PET scan as being exactly the same spot. So
Yeah.
for the indicative, they just didn't get it. And I was a little discouraged because I figured they'd use the PET scan as a guide for the surgery, and they'd pretty have a good idea of where to look. But it seems that was not a map.
Yeah. Let's see.
Anyway, I'm due to have a SBRT on the chest on the sternum in about a week or so.
Okay.
And then there's
What about that? What about that lymph node in the? I think you said right iliac lymph node.
yeah. So the idea is they want to go in with a what piece 5 storm procedure sort of a thing. That is go in there and zap everything, zap the prostate bed, take out all the lymph nodes, get everything they can. Uh, a little disturbing to me because I wanted to do the surgery in large part so I wouldn't have all this radiation.
Yeah.
And now we're going to get everything. And
Yeah.
the other thing I'm concerned about specifically is the positive margin. And they say that to get the positive margin, we're going to have to do the whole thing. Otherwise, we won't really have a good way of targeting that. So it looks like I'm doomed to do the whole
Pelvic region in addition to the prostate.
region, yeah. So
Yeah.
all the rest of the lymph nodes and all that.
Yeah.
Now I have some questions about this. One thing is,
Let me, Steve, can I just ask you one more question?
Sure.
What about cancer in your family?
Yeah, I have an older brother and my father with prostate cancer. So even though the genetic testing didn't show anything, there's an indication that perhaps it runs in the family.
Right. Well, what we know is they did the inherited gene testing, but it, it could be something in the somatics. Like, for instance, you could have BRCA2. Maybe your brother and dad had BRCA2 somatic mutations. But anyway, go ahead. I'm sorry I interrupted you.
Hold on a minute, Len.
Yep.
2 more questions. How did you hear about AnCan, Steve?
Oh, I did the web search and you guys popped up one of the first things. And I saw that this is just a couple of days ago. I figured, oh, this is coming right up. I'll give them a try.
No, it's disappointing because the UCSF boys know us real well. So I was hoping you were going to say UCSF told us, but that's okay. And have you signed up for our reminder? Do we have your email and contact so that we can send you a reminder before each meeting?
I'm going to sign up. I kind of ran out of time trying to figure out all the details
Okay.
of it, but I'll do it.
If you want to put your reminder in the chat window, which are the 2 little boxes, and send it to me, rather than do it yourself, I'm happy to sign you up afterwards.
Okay, if I can figure that out, you'll have to walk me through that. Let's not do that right now.
Dr. John, you have your hand up. Go ahead.
Yeah, hi, I'm John, Steve. I just wondered, after your prostate was removed, they sent it to the pathologist and got a whole new reading as far as Gleason scores and pathology. So, and that's even a better reading than the biopsy because it encompasses the whole prostate. So do you have any information about the pathology report on your prostate?
If you, I can do that. What I can do is I can, on my other computer here, I have the my chart from UCSF, and I can kick up the any of the stuff, and we can look at it in detail if you like, or you can ask me about it. So let me start my other computer and get the my chart thing going. So if you can hang on to that for a little bit until I get that kicked up.
Well, we'll move on.
I think without that, we're probably going to have to assume that you're actually a 4+5. But let's hear what they found when they looked.
Well, it didn't. That wasn't part of the thing. It didn't. The autopsy. That's what I'll be needing. What is it? The biopsy.
The surgical pathology report.
Yeah. Let me suggest.
Pathology report. Okay. Yeah, it didn't differ very much from the pre-op, but I'm going to be able to kick this up in a minute or two.
Okay,
so we can go on to talk something else in a minute now while I'm.
Yes, Steve, why don't you ask us your questions and then you can look for that when we get to the next and put it in the chat window. The way to use the chat window, there's 2 little boxes in the top right, and you click on that. It will open a box, and then at the bottom you put your message, and then you choose whether you want to send it to everybody or somebody in particular.
Okay, so this chat box, I open that up, I put my message in.
And send it to who you want to send it to.
Okay, or I could just send it to everybody and not have to think about that. And everybody can just ignore it as they wish.
You could do that.
Okay. So let me. I'm actually logging into my chart as we speak.
How about whether you're a veteran or not, Steve?
Yeah, I am a veteran from way back when, actually. Whatever that's good for.
Oh, Jim, you're not going to take that sitting down, are you?
Oh, no.
What
Well,
have
it
I started?
depends.
I didn't mean to cause commotion here. I'm sorry.
So Jim
But
runs an AnCan group for vets.
All right.
Yep.
Are we going or not?
well, hang on. I'm looking, scrolling this thing down. Here's a surgical pathology. How does that sound? Does that sound like something you're interested in?
That's exactly it.
Okay. Let's go take a look because I got this kicked up as we speak. Should I just read everything? Let's see. Okay.
No.
First,
Maybe just
left
the
mid
Gleason score.
Gleason 3+4 is 7. That's what I see at the very top.
That's
Another
very
one.
strange.
Another one down here. So that's the left mid gland margin. Then I have a prostatic adenocarcinoma, and that's also 3+4. Let's see what else is running down here. So let's see. So yeah, the comment is Gleason score 3+4 is 7. Approximate. Any other numbers you're looking for? Because I got them picked up right here.
Looking for Gleason 9 anywhere in any of the pathology sections.
Let's see. No, nothing like that. I don't think. Let's see. Let me take a look. Scroll down here a little farther. Let's see. So there might be. Let's see.
Or I guess it could just be a 5. You know, it might say 4+5.
Yeah, I see a lot of various details, but I don't see anything more about Gleason's. So let me tell you what the intro for the first Gleason is.
What? Steve, why don't you ask the questions? We're concerned about time because we've got 2 other new guys. So you have some questions. We can come back. We can come back to this if we have time or next week with pleasure.
Okay. Well, what I would prefer to do, which I probably will not be able to do, is get the positive margin at the bladder neck radiated individually, and then individually radiate the missed lymph node. Those are the 2 active areas in the pelvic region, and I wonder if it's possible to address those 2 issues individually without zapping everything, or if I'm just doomed to do the let's do the whole damn thing.
So the reason they don't want to do that, and we have a very good example of somebody who chose not to do it and then suffered about 3 years later. And actually, 5 years later, he went through 4 years of on again, off again, on again, off again, and ultimately needed the radiation. There's enough evidence with the iliac node and the bladder neck issue that the likelihood that you have disease across your pelvic girdle is high, even if they don't see it. Gotcha. So what they're saying is, let's just cover that issue now, because if we don't cover it in time, it can spread. And we also know there's something going on. We know we suspect there's something going on in the sternum. Otherwise, we wouldn't be doing the SBRT to the sternum. So what we should be doing right now is giving you treatment across the pelvic girdle. That's the first reason. The second reason is that Dr. Roach, who is really the senior radiation oncologist in that group, is a huge proponent of doing pelvic radiation across the whole of the pelvis, the whole pelvic girdle. So if you sign up, if you want to do something different and you're more interested in just trying to nail what they see, you'd basically have to switch your hospital. That I believe.
I think the reality is I'll be doing the whole pelvic girdle. So understood that. Now let me go on to a question I have about that. That is, I hear that you can burn up the rectal wall unless you have something like a spacer or hydrogel or something like that. So I was asking the doctor about that, and he said, well, no, you can't have it because you don't have a prostate, and so there's nothing to hold on to it, so he can't do that. What do you think of that?
Well, that's the first reason. The second reason is that the most vocal proponent against using Barrigel or Spacer has been Dr. Roach from the beginning.
So he's not going to be convicted of that anyway. So, okay, that's understood.
Right.
Next question.
And there are reasons for it. And whilst a lot of doctors use it, a lot of doctors don't at the time of radiating the prostate, because some doctors feel that it can allow the prostate to move so that the radiation direction is not as accurate.
Yeah, of course, I don't have a prostate anymore.
So you're not a candidate for it.
Okay. Okay, next thing is prostox. Should we be testing for prostox to see if I should be doing IMRT or SBRT?
It doesn't hurt.
Yeah,
Have you listened to our prostox webinar?
No, I haven't.
Okay, I'll put it in the chat window for you. It's worth listening to, from Dr. Joanne, who invented it. She did a webinar for us about 3 or 4 months ago. It's a really good webinar. And yeah, you know, if they're going, well, I say that. The fact is, the only place you're going to have the SBRT is to the bone. And that might, and I'm not really sure, Len or Ben or somebody, does anybody know how prostox relates if you're going after bone rather than soft tissue?
I do not.
So what I would do is call prostox. And there are, and I would find out whether a prostox test is relevant if we're doing bone-directed SBRT. I have a feeling it may not be. If they were using the SBRT to go after soft tissue, it might be relevant. But I don't think it's relevant when they go after bone, but I don't know. So you'll find details if you go to the webinar, and I'll put that in for you momentarily.
Another issue. I have bladder neck contracture. In other words, I have getting. What's this? In other words, what is this? Am I still here?
Yeah, we hear you.
Okay, good, because I've disappeared from my screen. Another issue is bladder neck contracture, something that would happen when they're stitching the urethra to the bladder. And it's not a big deal, but about every other night I want to self-catheterize, so I don't have to wake up 5 times to urinate. So it's not a huge issue. And I'm way better off than I used to be, because before that, I could not urinate, and I've been self-catheterizing for maybe 5 years, totally. But the issue is it seems like there is some simple surgical procedures to take care of the contracture. Should I have that done before the radiation?
Dr. John, you want to tackle that one?
Actually, Len, I don't think I can tackle that one. That's a good question, and I wish our urologist, Dr. Paul, was in the room tonight.
Yeah.
I've heard that you don't
I don't know.
I've heard you don't want to do surgery after radiation. Is there some truth to that?
Well, the radiation will inflame the tissues and make it more difficult for any surgery.
Yeah, no, it seems like it's a fairly minor surgery, but something that the people at UCSF oncology don't seem to know about. So it's kind of a funny issue here. I'm thinking that the regular urology department, they probably would know, but at the oncology, no.
Right.
I don't know what's happening.
So I would ask if they don't know, and I'm assuming you've asked Dr. Young and he's sort of given you this waffly answer, just ask for a referral over to the urology group. The head of urology is in that group. Trying to remember his name, Bruce something or the other. I can tell you in a minute. There's also a couple of very other good urologists in that group. So I would ask for a referral They're over on Parnassus, so you'll have to go over
I think
there.
it's Dr. Breyer. I think it's Dr. Breyer who's now head of that.
That's the guy. Yep, Breyer. That's the guy I was thinking of. Get a refer. Ask for a referral to Dr. Breyer to discuss it with him.
All right. I've actually done that, but I'll try harder.
We've got a question or a comment from Brian Hack.
Yeah. Hey, well, first, the good news, I guess. Your surgical pathology report was 3+4, not 3+5 or 4+5. So good on you. Second comment, the doublet therapy you seem to respond to very, very well. So that puts you in the castrate sensitive group, which is also good. I guess my question is that sternal node, the sternal met. Have you ever had any blunt trauma to the chest or anything that might explain that? Because it seems very odd that a 3+4, which is 7, would go straight to the sternum. I would think there would be other pathways before it would get into your bones, but I could be wrong. And I didn't sleep at a Holiday Inn Express last night, so excuse
the
my
thing is
ignorance.
they did the PSA right before the surgery, and there's nothing there. Then the PSA right about 2 months after the surgery is when it showed up.
You're saying the PSMA PET scan when you say
the PET scan. I'm sorry.
PSMA PET.
Yeah,
So it wasn't
before.
Okay, so it wasn't there before. All right.
Yeah.
Well, I'll tell you what. When was your last scan, and how long have you been on the ADT doublet therapy?
Let's see. I started that probably May, sometime late May. So it would have been May would have been the time I started the ADT and when I got the PET scan.
When did you have the PET scan?
Last one would have been May. First
Okay.
one was February.
So I think the acid test would be a repeat of the PSMA PET and see if that MET has disappeared, in which case it's definitely a cancer, spread to your bones.
Well, the idea is we're going to zap that, and I'm hoping it'll disappear after that.
Well, okay. Yeah, you can do that too. I guess I'm trying to rule out everything, which would mean a repeat of the PSMA PET scan. If that doesn't show up, then you definitely in other words, your ADT treatment has shrunk that tumor. If it's still there, then I would say that's a gray area, but I don't know if I'm making sense to you guys or not.
Well,
I'm sorry.
Brian, we've got to move on. I have a question or
this.
comment from Russell. Dr. Russell, go ahead.
Yeah, I don't want to delay this any further, but I have had a bladder neck contracture post-surgery, and I can definitely say that the irradiation will probably make that worse. So I think you really need to talk to your urologist, but I think I would defer any debilitations until after the radiation is complete. And of course, there's always a risk of injuring the sphincter muscle, and so that incontinence could be a problem in the future. But I think you definitely need to discuss that with your urologist.
Right. I was just going to say that with the PET scan, I think with my PSMA, with my PSA score so low, we're not going to get anything from the PET scan at the moment.
Russell, did you have another point you wanted to make, or your hand went up again? No. Okay. All right, Steve, we've got to move on.
Thank you.
Come back next week if your story is still untold, and we'll be here.
Okay, thank you.
Yeah, you're welcome. Okay, we would like to go to Eric Baker, who I believe is also new, right?
Right. And Len, you have some information on Eric Baker that I sent you.
Yes, I do. You'd rather I just read from that?
Well, maybe read it, and then it'll help you. You can skip over some of the stuff. It might help fill in. I know Dr. John will make notes from it for sure.
Okay. Problem is, I need to log into my AnCan email.
Okay. If you can't find it, I can find. I have it then.
Yeah, why don't you go ahead, Rick? For some reason, I can't log in.
Okay. All right. Bear with me. I'll pull it up right now. I was just posting something. Here we go. Okay, so Eric sent us an email earlier on today. We have his email address, Len,
Okay.
and I'd like to read to you what it says, and then make some notes as I'm going along on your sheet, okay? And then it'll help you, and we'll hopefully be able to cover it a bit quicker.
Okay.
Wrote to info saying, I'd like to join one of the groups, but do not know what group that I fit into. Here's my story. I was diagnosed with prostate cancer in August 2023, following a prostatectomy that revealed, I think that should be a PSA test, that revealed a PSA of 42. Gleason score 3+4. This sounds like Steve D, doesn't it?
Yeah.
Gleason score 3+4, bladder neck invasion. Oh my gosh, Eric. Multifocal disease, focal extraprostatic extension, perineural invasion, and positive surgical margins. So obviously there was an RP and a PSA at the beginning. That was sort of a mixed thing. And he was staged T3A. T3A, gents, means that they suspect that the disease is outside of the gland, but it's not seen in the seminal vesicles as yet. Despite surgery, I experienced biochemical recurrence with a rising PSA between December 2023 and December 2024. PSMA PET scan prior to starting therapy showed no uptake at the prostate bed, but suspicious left periaortic node activity and ill-defined periportal upper abdominal soft tissue densities concerning for metastatic lymph nodes. In December 2024, I began ADT with Lupron and started salvage radiation on late December 26th, Boxing Day 2024, completing 39 treatments by Feb the 19th, 2025. As of September 2025, my PSA remains undetectable, and I am continuing follow-up monitoring while on ADT. And that raises a couple of comments with me, but I'll turn it over to Len to fill in the blanks.
Okay, so you've had a prostatectomy, salvage radiation therapy, and you've been on Lupron. And what was there any other hormonal drug they put you on, Eric?
No, just Lupron.
Just
6-month
Lupron.
shot.
Okay. We would like to have seen you on a doublet therapy, but how about genetic testing for you?
They did do in VTA, double whatever. You mentioned some things earlier, and I didn't know what that meant. But the BCR2 in both tests came back as abnormal, but yet it's not in any proven. Whatever that genetic strain wasn't proven yet to be part of the cause of prostate cancer.
Who knows?
But you did have a mutation in the BRCA2, BRCA2.
Correct.
That was somatic mutation.
Not part of the clinical recognition or recognized causes to prostate cancer at this time. they keep telling me to check back with them.
What
Well-
was the mutation?
I can look it up for you real quick.
I thought he said BRCA2, no?
It was a BRCA2, but
Yeah.
if you were looking for it, then Invitae gave a lot of details in that report.
Well, BRCA2, I mean, from what we know, BRCA2 is BRCA2. It might have been a what do they call it? Variant? What do they call it, Len?
Oh, variant of unknown significance?
Yes, that's exactly what it was. Yep. Yeah.
But if it's germline, I mean, it could have been a VUS, but I think they usually consider that a BRCA2 VUS is still a BRCA2, but I don't know. Don't know enough. So I would sort of do some more investigation on that. But go ahead, Lynn.
Okay, so I would.
How about the stuff at the top, Len? Let's get some answers to some of the stuff at the top.
Yeah, so your PSA was 42. You were 3 + 4. You had
Age, Len. Age
yeah.
and location.
Oh, I see what you're saying. Yeah, how old are you, Eric?
So when I was originally diagnosed, I was 47.
Okay.
Okay, and that was what year?
2023. So I'm 49 now.
49.
And
Okay.
Nice.
I expect a
And-
birthday card this December for my 50th.
And Eric, where do you live?
Lafayette, Indiana.
Okay. Yeah, I would talk to your doctor about going on a second line anti-androgen because you certainly, that's what I meant when I said a doublet therapy. So Lupron is a monotherapy. The doublet therapy would be adding either an androgen receptor blocker or abiraterone. If it were me, I would ask my doctor about is that appropriate or not, because you do have metastases, left periaortic lymph node. You're young, and you could certainly be treated more aggressively than you are being treated by standard of care guidelines. And you may, we're not sure, you may have the BRCA2 mutation, which carries even a less rosy prognosis. So I think I'll just open it up to anybody else who wants to comment here, unless you want to have any more questions for us, Eric, before we do that.
Well, outside of waiting, that's what I've been told to do now is wait until my December appointment to see my testosterone levels. Prior to, since 2013, I've been in the 100s. So then the Lupron shot provided a level that was probably 0 at one point, and my last appointment in July, it had rose to a whopping 3. So their concern is once I get to normal levels, which for me would be over 120, 130, that's when there's real suspicion it'll be right back again.
But why would it go up? Aren't you still on Lupron?
It was a 6-month shot, 6 month starting December 2024.
So you should have had a second shot.
Should I? I don't know.
Well, yeah, 6 months from December would put you in June 2025.
So, Len, can I jump in here?
Yeah, go right ahead.
Eric, if it were me, there's a lot of issues I'd be concerned about here. Where are you getting treated?
Currently at St. Franciscan. So I started out at IU Hospital with my urologist, Dr. Stanton Regan, and they, after it had come back, they could not get me into an oncologist for months and months. So I immediately went to the other hospital here locally in Lafayette at St. Franciscan, and that's where my oncologist and radiation oncologist
Okay.
are.
So, yeah, to put it bluntly, your oncologist and your radiologist are out of touch. I mean, I hate to put it so bluntly, but that's why you're not getting a doublet. Most likely you would have done if you went to Simon, because they are an NCC, they're an NCI hospital. I think they're now an NCCN hospital too. So you're not getting the right treatment. They don't understand prostate cancer. There are a number of reasons why we know that. One, as Len said, the standard of care is 2 drugs, and they only gave you 1. Secondly, they gave you a 6-month depot shot, which they don't work because they lose efficacy in not for everybody, but for a lot of people, they lose efficacy in the last few months. So you're better off getting 2, if they're going to put you on that drug, give you 2 3-month shots. In addition, a lot of urologists now, a lot of oncologists now are prescribing a different drug, which is a pill, which does the same thing and makes your testosterone come back quicker. So what's happened is you haven't gotten treatment intensification. You're not alone. Probably about 70% of men don't get treatment intensification. It's a big issue that we're all focusing on, trying to get more men to get the proper treatment. Secondly, they're not using the best treatment options for you. So somehow or other, we got to get you to somebody who knows what they're doing, and quicker rather than later. You might want to call. You might want to call your boy back. What did you just told me his name? Who was the guy that gave you who did your surgery?
Stanton, Dr. Stanton.
You might want to get hold of Stanton right away and say, I'm not getting proper treatment. I'm not on the right drugs. I need to see a genitourinary medical oncologist. And we can put that in the chat window for you. Somebody will write that into the chat window, genitourinary medical oncologist. It's often abbreviated by us and others to GU medical oncologist. And you need to see a GU medical oncologist as soon as you can. We can find other GUMOs for you. Probably
I'm in between Indianapolis and Chicago. Is there any?
Yes.
Any...
Yeah. So I was just going there. So we could probably find you somebody in Ann Arbor at University of Michigan. The other alternative would be to go to Chicago, where we can definitely find you somebody. We don't love the current GU medoncs at University of Michigan, but we have some really good ones at University of Chicago. How about Columbus? Is Columbus in equal distance?
Yeah, Columbus about equidistance. Yeah, to Chicago.
And we can find. So you tell us. We can make good recommendations at Columbus or at University of Chicago.
Which one's the best?
And I would say Chicago.
All right, then I'd like to hear about that.
I would say Chicago. We would send you to Dr. Schmulowitz. We'll put his information in the chat window for you momentarily. He treats a number of our guys, including one of our board members. He's flexible to work with. He really understands the disease. And he'd certainly be somebody that I would consider taking my care to. And I prefer him to the guy that we could. There's a couple of guys at the James, but I would prefer going to UFC. And I wouldn't really consider right now. I would consider. University of Michigan for other things, like for surgery or for active surveillance and other things, but not right now. particularly for advanced care. We have there's a doc there's a doc up in northern Michigan that I think Steve Rue sees, who's good, but I would rather go to, and I don't mean to offend Frank Chambray here either, because he goes to the James, but if it's even up and I'm deciding, I'd go see Schmulowitz. So that's my suggestion, and I'll put it in for you. And if that's what you're going to do, we can send him a heads up note, but you call and try and get an appointment. If you don't get one, that's what I do. Call and try and get an appointment with Schmulowitz. Tell him AnCan sent you. If you cannot get a quick appointment, let us know and we will backdoor it.
So you think now's still the time to don't wait? Let's keep.
Well, yeah, because I mean, you know, they only put you on 6 months, which is not really it's not really understandable since they've seen metastasis. They gave you a 6-month depot, so it's like, do this for 6 months and come and see us later. No, it's not the way. That's not the way to treat. If what you're telling us is all correct, and there's evidence of metastasis in the periaortic node, and you've got ill-defined periportal upper abdominal soft tissue densities that are concerned. We're not docs, but if it were me, I'd be thinking they'd undertreated me. But let's hear from. And Tim Marshall has his hand up because he wants to know if you're a veteran.
Yes, sir.
Oh,
You are. Okay,
Yes.
so just a quick word for both the vets. We have an outstanding veterans benefit and health care group to make sure you're getting all the benefits and all the care you need. Both the vets, including Steve D, register at the VA as soon as you can. You want to be dual registered. And the reason for that is because if you need drugs, you're going to get them much cheaper through the VA than you are through the other insurance that you have. Come to the group. When we sign you up, we'll include that. We have other veterans. We have other really good programming. And Eric, we also have an under 60s group for men with locally advanced and advanced prostate cancer that only meets once a month. But you should come to that because you'll find your peeps in that.
Okay.
And we also have a veteran speaking freely group where you can unload a whole bunch of stuff if you want, because of the living in civilian life as a vet and other things. Go ahead, Captain Jim, and I'll put in the Schmulowitz link for it.
yeah, to both of you, we meet tomorrow night. So if you will put your email addresses within the chat, I will send you the info to connect tomorrow night if you're interested. So.
Okay,
Great.
I have Eric Baker's email. I'll send it to you right now. I don't have Steve D's.
And I sent Steve D. I sent something to you in the chat, asking you a few questions. So.
Okay.
Okay.
So keep going, and I'll look for Schmulowitz's number.
So why do you think I was told that those, not to worry about those?
Because general oncologists don't understand prostate cancer. It happens all the time. And if you've listened to any of our recordings, I think we say more often than anything else, you must go to a specialized genitourinary medical oncologist. Frankly, they don't get it. And it's a problem. And they finish up treating you in a way that is insufficient. Many GU med-oncs, they don't stay up with what's going on. They probably haven't read anything about, you can ask your medical oncologist, have you read anything about treatment intensification in prostate cancer? There's been a huge amount. That's the reason why. They don't know what they're doing.
Also, Eric, I think it would be a good idea to get a second opinion on your pathology report. Oh, wait a minute now. I'm sorry. I'm confusing you now with Steve D. Steve D is the one who had possible Gleason 9, but you did not, right? Eric, you were strictly on
No,
3
no.
plus 4. Okay,
Yeah,
sorry.
3 plus 4.
And that was confirmed in your in your post-surgical pathology.
Yeah, and they took out 8 of originally it looked like it had spread to the iliac chain of lymph nodes in the scans previous, and then they took 8 of them out, tested 3 of them, and they all came back negative.
Okay.
Let me just say that it's a really nice thing that your PSA is currently non-detectable, because even though you have been undertreated, so far it's going okay. So as long as that non-detectable PSA was very recent, and as long as you get to Dr. Shmulewicz soon, should be fine.
Thanks, Dr. John.
Rick, would you like to talk about
Mark? Were you thinking of Mark, Len? Or?
Mark? Thank you. Been a
Oh,
long day. Yeah,
okay,
you said you wanted to give an update on Mark.
I did. I just want to make sure that we're all done, and you've still got one more newbie as well.
Oh, I thought we cut it down to 2. We have a third one?
3, yes, we have 3, Len.
So who's the third?
Mariah.
Mariah.
I'm representing the other newbie.
Right.
Do you want to go
Mariah,
to me next, or do
Mariah,
you want
Len.
to?
Yeah, go ahead, Mariah.
Okay,
Sorry about that.
well, you're fine. Yeah, no, and thank you. It's so impressive to hear you guys just, yeah, this is an amazing forum. So I'm here representing my husband, Henry. He is 53. We live in Brooklyn, thank God. We heard of AnCan because I was on a zero prostate call with Jim. And so Jim pointed us that direction. And most of all, my friend Cynthia, who I met there, whose husband Jerry, she highly recommended you guys. So Henry was first diagnosed end of June this year. When he was 50, he did his first PSA. It was a 6. When he went this year for his second checkup, he was a 14. And so his doctor at that time was a urologist, or is a urologist, Ariel Schulman at Maimonides. And after him, we quickly moved over to MSK, where we're now with Dr. Carver as a surgeon and Dr. Sutton as radiation oncologist. When we went to MSK, they regraded his tumor. So the Gleason score now is a 4+5. And I can give you details of the biopsy. And since then, we did the PSMA PET in early July, which says no spread. I mean, more official words, but MSK seemed to agree no spread, so local. So that's the first like 6.5 questions. You want me to go into question number 7 with the biopsy?
Go right ahead. You're doing well.
Thank you. Sorry, I'm an engineer who manufactures pharmaceuticals, so I don't know this arm of it.
Oh,
I don't know this arm of it, but I know other bits. So yeah, just enough to be dangerous. So his biopsy, it looks like it's basically all in the left prostate. So they did 13 needles. 7 were on the left. Of the 7 on the left, 6 of them scored. Of the 6 that scored, half of them were 4+5, half of them 4+3. And of those that scored, 3 of them said perineural invasion, and 1 mentioned crib reform, which I had never noticed until you guys asked that question. I have no idea what it means. So, FYI, what's it mean?
well, if you come to our webinar on the 30th of September. I will put that link in the chat window momentarily, the registration link. You will hear probably the recognized #1 pathologist in the world explain what cribriform is.
Okay.
Meanwhile, we can pull in our own Ben and give us his
Yes, Ben.
definition.
Come on, Ben.
Yeah, I should have pictures at the ready. It when you look under the microscope, it looks like it has slits. Cribriform, I think, means sieve-like. So that's not what you expect in ordinary prostate cancer. It's well, to put it bluntly, it's an adverse sign.
Okay.
It's not good to have.
Okay. Okay.
So, Mariah, what therapy, if any, has Jim had so far?
Yeah, so Henry. So
Henry,
Henry so
sorry.
far, yeah, no, and so far no therapy. They tested him for genetics to see if he was BRCA, to see if we could do a clinical trial before surgery, and he did not have any variants of clinical or uncertain significance. So really where he is right now is all three of the doctors he's talked to have recommended that he go into surgery, and he's been given a surgery date of October 3rd, and that's the direction he's going. I think he prefers that because he's scared of ADT, and the radiation oncologist said based on his age at 53, yeah, they all preferred to go straight to surgery. So, I really just came here to say, is it that straightforward? Is surgery the right next step, or are there any red flags or weirdness that would prompt us to do something else?
Rick, your hand is up. Go ahead.
Yeah. So this is a bit of a tough one, Mariah, because, well, let me ask you a question. Did any of your docs at MSKCC suggest to you that you run their nomogram?
What does that mean? No.
A nomogram is a large database taken over a period of time that compares your husband's disease demographics to their data bank and tells you the likelihood of certain outcomes. Now, it isn't for sure, because there may be other factors, but it'll give you a good idea as to how successful surgery will be.
Mhm.
Now, given what you tell me, or tell us, excuse me, my guess is that your what was his PSA? Did you tell us that? Oh, 6 to
Yeah,
14. It was 14.
yes,
So
yeah. So it doubled over 2.5 years. That was the
right.
time over
But
doubling. Yes.
given his PSA at the time of diagnosis and what you found, my guess is that there's going to be less than a 20% chance that surgery alone will suffice.
Yeah.
Henry was just kind enough to put it in, but he only sent it to me by mistake. He meant to send it to everybody. God bless you, Henry. That's
No,
Henry's.
those are my little private love messages to you.
Oh, well, thank you. Thank you, Henry. But I'm going to send it to everybody because it saves me looking it up. And you can click on that, Mariah, and after the group, you can run it, or you can run it during the group and put a note in the chat. But if
Okay.
you run that, you'll find that he doesn't have a high chance. In my own case, I had a 30% chance of success. I was 56 with 4+4, and similar PSA, 15 plus something. And I said, no, I'm not going to roll the dice on the surgery. Now, at 51, is it worth it? Well, we really don't know. There's not been very much evidence. The very best I've ever gotten is from one of the best surgeons in the country, really one of the sort of the venerable older surgeons, but certainly comparable to Laudon or Eastham. And frankly, I would rather see you with laudonoristum if you're going to do surgery. I don't know if you're going to be able to change, but I definitely would want to be with either laudonoristum for a case like this. And he told me, this is Peter Carroll at UCSF, he told me that if you add the surgery, it probably improves all outcomes by about 3 to 4%. And what I said was, look, if I'm gonna have to do hormone therapy and I'm gonna have to do radiation, do I really want to do the surgery as well? And there's a bunch of guys sitting in this group, maybe not quite as young, who did surgery and then found out they needed to do hormone therapy and radiation anyway. And those guys said, I wish I would have just gone straight to hormone therapy and radiation. So this becomes a really significant question. And really, you may even want to involve, for advice, you may want to involve a medical oncologist, a GU medonc, and it wouldn't be untoward to say, do I really need to do the surgery? And if that's the case, we'd say, go see, probably at this point, and to get an appointment relatively quickly, I'd say either Dr. Rathkoff, because she's lovely and you might be able to get her quickly, or Dr. Dr. McHugh, MCHUGH. Both of them know AnCan pretty well. We just had a 51-year-old do surgery, but he had BRCA2, and he wasn't 4+5. I think he was 4+3. But it's a decision that has to be taken very, very seriously. Is there anybody here on the call who did surgery and then finished up having to do radiation and hormone therapy and felt like they never had a chance to make that decision in the first place? And Ben Nathanson has his hand up first.
So basically, it's to reiterate what what Rick was saying. It's not going to be that easy. You get the surgery and you get to avoid ADT. The chance of, especially with a high grade cancer, it's very, very likely that he will need both subsequent radiation and ADT. And in fact, what Rick was saying, that it is an option. It is an option that many people wish they had taken, to just do the radiation. Yeah, it's not going to be as you suspected. It is not going to be that easy.
Can I ask? So when we went to MSK, the first, I mean, I had asked for a medical oncologist based on some recommendations from people I work with, but they directed me first to a radiation oncologist and a surgeon. The radiation oncologist, when I shared what I shared, he said, "Oh yeah, I wouldn't do radiation and ADT. I would go straight to surgery." Is there a reason a radiation oncologist would say that, but a medical oncologist would have a bigger view?
Well, I guess what I would say is the following. I suspect the radiation oncologist is saying do the surgery first because of his age. And it's an okay argument, but there's many people who, not many people, but there's a good number. What I would do is go back to the radiation oncologist and say, I want you to be specific. How much better is the outcome going to be if he adds the surgery to radiation and hormone therapy? Now, if he comes back and says, well, maybe he won't need radiation and hormone therapy, he's blowing smoke up your tushy. Okay? Because he can run that nomogram, and I suspect you're going to be somewhere between 10 and 20%. I don't know for sure, but I suspect you're going to be somewhere between 10 and 20% chance of success. And ask him, how many people have you seen do radiation. How many people have you seen that have not needed radiation or hormone therapy with 6 out of 7 cores that are 4+5? And this is, you know, they don't expect these questions. This is why you come to groups like this, because we give you the hard questions to ask your doc. We can't give you the medical advice. I can only tell you what happened in my situation. Let's just go to a couple of people who had somewhat similar situations. Donald.
Yes. So I think I had a Gleason 5+7 out of 10 out of 12 cores. My PSA was 4.2. And the surgeon said, "We got to keep you safe. We got to get this out. Let's get it out." Well, I have suffered incontinence. I have suffered impotence for the last 10 years. So it's like if you go to an auto mechanic, he's going to want to change a part.
Yeah.
If you go to a surgeon, he's going to want to do a surgery. If you go to a radiation oncologist, you're going to get radiation.
Yeah.
So I would, for my personal case, I would have done watchful waiting still, because I don't think that my outcomes.
Watchful waiting. I have to interrupt you. Under no circumstances would you, I hope, would you have done watchful waiting, Donald. You might have done active surveillance, but with a lot of disease, it might not have been right. But I guess what I want to say to you is, why do you think the radiation oncologist suggested that Henry should do surgery in this case?
I wouldn't speculate, because I've been through probably about 10 different surgeons and radiation oncologists and various people, and my outcomes have not reflected what their advertising is.
Okay, happens frequently. Dr. John.
Rick? Yeah, I just want to say quickly to Mariah, I'm going to just speculate here, but I'm thinking probably the radiation oncologist was thinking, well, theoretically, Henry's cancer is contained. No evidence that it has spread. But with he's a radiation oncologist, not a medical oncologist. Maybe he doesn't quite understand the aggressiveness of a Gleason 4+5 with as many cores positive as your husband had. And we know from experience that it's highly, highly likely that there are micrometastases that have already escaped the capsule, even though they're not detectable. So, you know, the radiation oncologist might have been thinking, let's just cut it out and we'll be done, because it hasn't spread yet. But it's, you know, practically, no. It's empirically, that doesn't happen. I've been doing this for 10 years, Rick, for more than that. I've never known anybody with a Gleason 9 who had surgery and they were cured.
Okay.
Never.
Yeah. And that's what I mean when I've heard some numbers where they say 60% have reoccurrence, other that said 85% have reoccurrence, and yeah, all those numbers make me uncomfortable.
Okay, well, that's why we want you to run that nomogram.
Okay, so the nomogram I can do, and then the other thing you're saying is you would really go to a medical oncologist. You had mentioned 2 people. Were those both MSK doctors, Dr. Raddick and Dr. McHugh? Okay.
Dr. Rathkoph, Rathkoph, Dr. Rathkoph. I know a Raddick. Do you know a Raddick? Because I happen to work with a Raddick one
Wait,
time.
tell me again how to spell her name. R-A what?
Rathkoph.
Rathkopf.
I'm putting it in the chat window. I'm putting it in the chat window.
Thank you.
And Dr. John, go ahead.
I want, my point has already been made by my colleagues. So while I was listening, I ran the nomogram for you. And I want to give Rick a first prize for his guess. I came up with a 15% progression-free probability at 5 years after radical prostatectomy.
Okay. Yeah. So 15% chance at 5 years that the PSA hasn't spiked.
That ties in with the 85% chance of recurrence that you heard about. How about we're going to be running late, guys. I just want to tell everybody who has asked for time tonight, we're going to be running probably a half hour to 40 minutes late. Len, if you need to go, I'm happy to take over when you're ready to go. We have one other question on here. Well, Jeff Markey, I've answered your question in the chat window. If they did surgery, they might be able to spare the nerves on one side. They're almost certainly going to have to take the nerves on the side where there are 6 positive cores. Was there anything else you wanted to say, ask Jeff or say?
Well, they should ask the doctor if that can be done. And
Okay,
at least
let's move on because we're really short of time. But the likelihood is that the doctor's going to do nerve sparing surgery if he can. The likelihood is he might be able to spare on one side.
Okay. Well, Rick, when we move on, we're moving on to you.
Oh,
thank you, Mariah. Thank you very much.
Yeah, for
Thank you
Mark
all.
Valens.
Appreciate it.
Okay, gents. Mark Valens sent me a note about half an hour before the meeting, and I'm just going to read it to you because he asked to be remembered to everybody. He said, "Hi, Rick. I was hoping to join you all this afternoon, evening, but I've been in the hospital for 6 days and I'm not up for a meeting. Staph infections, partially collapsed right lung, and metastatic spine pain. I hope to be feeling better tomorrow and will give you an update when I can. Greetings to all. Really sorry to miss out tonight. It's become an important part of my week, Mark." What I am going to do is put Mark's email in the chat window to everybody. I would really love for you to reach out to him and just send him your best wishes and tell him how much we miss him. He has been going through a rotten time, and I, it upsets us all, especially me, because he's such a good guy. So that's the update. Can't tell you any more, but I'm putting Mark's email in there right now.
All right. Thank you, Rick. I'm sure we all feel the same way as you about Mark. Mark, if you happen to be listening to this on YouTube recording, all our thoughts and prayers are with you, brother. And hope to see you back with us next week. Hope you get out of the hospital. All right. Let us go then to JD Fairbanks. DJ Fairbanks.
Hi there. I think I'm the spokesperson.
Okay.
As I before, we were
That's
here
a lot. Yeah. So you said you were last year, I think you said May?
in May, yes. So I just wanted to give a follow-up and ask a couple questions.
Go right ahead.
Could you just remind us of, and you can put it as a private message to me or to Len, but can you just remind us of your first and last name so we can track our notes, because we can't get it from DJ. And I know I've seen you before, but I can't remember, to be honest.
Okay.
Rick, excuse me for interrupting. I've already looked around and neither I nor LGL have any notes on DJ or Fairbanks.
I think I do. So if you could just send it to me, okay, put it and send me a last name too, so I can pick it up and show it to and send it to Dr. Jack, please, to Dr. John.
Okay.
Thank you. Thank you. Got it. Okay, I wasn't sure if Fairbanks was where you were from or what it was. Got it. Okay.
Okay. I don't know how much of a review you want me to say.
Well, if you could wrap it up real quick, because we have so many more guys to get to.
Okay. All right. So when we were here, we were about to be, we were in the middle of chemotherapy, docetaxel and carboplatin. And I think the group thought we were being overtreated. And we met with Dr. Heath at Mayo, and she said, continue on. And when you come back in 3 months, maybe we'll consult with SBRT. He has METs in the lung only. He completed the chemotherapy. We went back last week to see Dr. Heath and discovered that he had a bilateral pleural effusion. And so he had those drained. And our doctor here in Michigan is leaving and going to Midwest Start. And so we're feeling a need to have a different local person to follow up on this complication. And just curious if you've had anyone experience the capillary leak syndrome from docetaxel. We're hoping that's what it is and not a malignant pleural effusion. And yeah, I guess that's it. There isn't really a GU person close to us other than in Ann Arbor. So I found your comments earlier about Ann Arbor interesting. Chicago is a little bit further, but our other GU onc was just 45 minutes away, and that felt good. To have somebody 3 hours away or 7 hours away feels a little too far. So just curious what you all think.
So you say your other GU, so you did find a local GU medical oncologist?
Yes, and he's going into, we'll see him for the last time this week. He's going to a company called Midwest Start. He'll be doing clinical trials.
Okay, well, my first suggestion would be to ask him who locally he would suggest. Steve Ruud, weren't you on the call? Didn't I see you on the call?
Yes.
Who's your guy? Who's your guy that's up in the
Dr.
northern?
Caleb Fidock. Dr. Caleb Fidock. He was the.
Would you put
yeah,
it
I think
in the
I
chat?
did. I thought I did that last time they were here. I'll do it again.
Please, and also his location.
Yes.
I think if it's Petoskey, it's like 4 or 5 hours. So
That's Petoskey. Yes, he was kind of handpicked by Dr. Heath. He studied under her.
we're hoping she can give us another recommendation, given that she was here in Michigan for so long. But we didn't want to do that in the portal. So, and we didn't. She was putting out fires with the pleural effusion, so we didn't really have time to talk over everything.
Well, so she was with Carmenos Cancer Center down in the Detroit area.
Dr. V.
And she may know some other folks, but off the top of my head, I don't.
Okay, so there is somebody. I'm sorry, I stand corrected. There is somebody in Chicago, in Michigan. So this is for Eric too, as well. I still would rather see Shmulewitz, but Dr. Vaishampayan, who used to be at Carmenos and Dr. Heath took over her job, she's now at University of Michigan.
What was her name?
I'm gonna. They call her Dr. V for a reason. Okay, I'm gonna put her name in the chat window. Okay. And you, her patients liked her a lot. You can look her up. I probably have. Let me just send this to everybody, and I probably have a link for her. And she was at Carmenos, and then she went over to University of Michigan. Dr. Heath took over from her to head up the effort at Carmenos, and then she left and went to Rochester, Minnesota. So, but I'm glad that you saw Dr. Heath. I'm very glad that that's who you're now seeing there, and she's great. She's she's great. What can I say? So I hope you thought so too. You may not have thought so.
Well, we thought so, but she was so busy putting out this fire, and we haven't talked to her ever since then. And she's hard to have a conversation with, but we look forward to it.
Well, write to her and say, this is what's happened. Could you give me a call? And the chances are she's she's going to do. So here's the link for Ulka Vaishampian. And she might be a closer option for you. Okay, there's a link for Ulka Vaishampian.
We didn't give Diane a chance for folks to answer her question about capillary leak syndrome with docetaxel, possibly causing pleural effusion. Anybody have any information on that? Sorry.
Yeah, apparently it's also pretty rare.
Yeah.
We've got three doctors. We do have three doctors in the room, but I don't think any of them can contribute on this one.
Sorry, I'll have to research it.
Okay.
Also, there was a lot of brain fog and fatigue when we last met you. Is that still going on?
That's for you, Diane and Jack.
Fatigue, yes. Round 6 is complete about 5 weeks ago.
Okay. Anything else for the group? Any questions?
I can add something about taxol leakage. When I was going through chemo, I fell asleep and the needle came out and into the tissue. It destroyed a good deal of the tissue in my arm at that area, about 3 by 4 inches. And that was when they caught it right away and pulled out the needle and reinserted it at a different location. So it is not a fun thing to happen.
Yeah. The capillary leak syndrome is more of the overall systemic capillaries are leaking protein and fluid. And so not only did he have swollen ankles, but the cough got bigger and bigger, and there was a leader taken off each side of the right and the left lung because I think it must be the mets in the lungs made him more susceptible to this side effect. I don't know.
Well, I've got a lot of mets in the lungs, but that was kind of a side issue.
I wish it was a side issue.
Yeah.
Well, yeah, that's a poor choice of words.
All right. Well, we've got quite a few guys to get through yet. Jack and Diane, good luck to you. Come back next week. Let us know what's going on. Steve Rue, you are next.
It's getting past my bedtime, but I'm on the East Coast. I had an interesting event, and I'm just curious if anyone else has had hearing loss problems who's on abiraterone and prednisone. I had a sudden loss of hearing in my left ear. About 6 weeks later, I saw ear, nose, and throat ENT specialist who told me that there was a side effect of abiraterone, and I corrected her. I said, I've memorized every single side effect. And it turns out that it's extremely rare. Her concern was that it was a sudden loss, so we're going to have an MRI in about 2 weeks. But I'm just curious, is that something that you gents have ever heard of before, hearing loss with abiraterone? Is that as rare as they're telling me, or what? That's all I got, really, to try to get some feedback. That's all.
I haven't heard that with abiraterone, Steve, but what about, are you taking any erectile dysfunction drugs? I've heard of sudden hearing loss with those. No, okay.
No, and her concern is it might be a blood clot or maybe something even worse, a possible tumor or cyst or something, and that's why we have an MRI set up here for 2 weeks. Take take a look at what's going on in here because she's pretty sure it's nerve related.
I've just been down the Abbey list again, and it's not there.
No, it's not. But when I got a hold of Dr. Fadak, my buddy, my buddy Caleb, he said they had to do some digging around, but it turns out that yes, there's some very rare, very rare situations where they think that that was related to abiraterone, possibly to prednisone as well. So
When is the MRI, Steve?
2 weeks from now.
Still another 2 weeks, huh? Okay.
Yeah. Yeah, I just was wondering if you guys had ever heard of such nonsense or what. I started to correct her. As I said, I've already memorized all my side effects, and that's not one of them. But she pointed out something, I forgot what it was, ototoxicity or something diminishment or some. She said you probably skipped right over it when you read it in the fine print, and I swear I never saw that in there. Anything I've ever read online, talking to you guys or talking to Dr. Google or whoever, I haven't seen that.
Steve, have you ever had chemotherapy drugs?
Not only what I'm taking now.
Which
you mean Orgovix and abiraterone.
Oh,
I don't
okay.
think those are considered.
No, that's not chemo.
No.
Okay. Because I know certain chemo drugs can cause ototoxicity. Okay. Thanks for sharing that, and let us know what the MRI reveals.
I will do that. I'll give you an update in a few weeks.
Okay, thanks, Steve. Joe Commanda, go right ahead. Joe still with us?
Sorry, I'm going to put it off till next week. I don't need to talk to you tonight.
You sure?
Yeah.
Okay. All right then. Frank Chambra, you are up.
My situation is I'm scheduled Wednesday to start it would be my 7th round of Pluvicto. I've already finished 6 rounds. I finished my 6th round in April, and my cancer came back. And so I'm scheduled for a full year's worth of 6 more Pluvicto treatments, scheduled to start Wednesday. I don't know if any. We're going to talk to the doc too on Tuesday, which is, everything's happening fast. I missed last week's meeting. Sorry about that, because I really wanted to talk about it last week to have some more time on it. But so the other opportunity is what I talked to Rick about is the alpha trial, and there's another trial that they have that I could have got into, but we're going to go with the Pluvicto because I had such good results. Today I went swimming. I want to say, we all have problems, and I always try to be real positive. But I was at the rec center today, and there was a guy in the locker room, and he was blind, and he had some kind of head trauma, and he made him blind. And he was a young guy, and he couldn't lock his locker. So I was like, "Yo, man, you need help?" He had his magnifying glass. He's looking at it and says. So then I went out in the pool, and he was like, "So this guy's blind. He had such a great attitude. He was just smiling and so thankful." And it was just a good day. So anyway, that's my situation, and I'm open for thoughts. Am I the first person to ever do this? I don't know.
Frank, how low did your PSA get before it started going back up?
Didn't it get to, I think, 0.89 or something? It was 200, and then went to 0.89, and now it's up to 1. I don't even know. I gave you the report the last time. I don't have the stuff in front of me, and my mind is so shot right now. I can't think of that.
That's close enough. So you went way down, and then
it's 1.89 right now.
Okay, so is your insurance going to cover these additional Pluvicto?
Here's the blessing: is that Novartis is going to cover it. They're going to cover a year's supply of Pluvicto, and the Medicare, my Medicare supplement will pay all the doctor's bills at Ohio State. So I've been blessed once again. I mean, why? I've been I'm not, it's just, anyway, I don't want to go down that road, but anyway, I've been just blessed and I don't deserve it. So I'm just so thankful. And I'm willing to do it. I'm strong. Hell, man, I set up a bed downstairs in my basement right here. I got the music how to leave, and I'm prepared. It's like kicking a drug habit every 6 weeks. That's how I look at it, because I was a heroin addict and I kicked a lot of heroin habits. It's a piece of cake. My last heroin habit I kicked 42 years ago, and it was pretty bad. Real bad, and I survived that. So doing Pluvicto, I came out stronger on the other side. So I don't know, it's torture. I'm not going to lie about this it's like going through torture a week and then you rebuild. But anyway,
Frank,
besides that, I'm the man to do the job. Go ahead.
Frank, I would talk to your doctor about maybe doing a PSMA PET scan.
We did one.
After the 6 treatments, they did another one?
Yes, they did one.
And they still had lesions lighting up?
Yes, the lesions came back.
Okay.
At first there wasn't, and then they did another PSMA PET scan, and yeah, they're lighting up. In various places, my spine, whatever. But anyway, I don't know exactly where, but I wish my wife was here because she's a nurse, but
okay.
So
you never bring your wife, Frank. You always manage this yourself. You know that. So let me.
I do. My wife manages my life on the medical end of this. I'm so thankful for her. So go ahead.
So let me give people a little bit of background because there's questions in the chat window. 6 Pluvicto are all that are approved by Medicare and the per the FDA. So Jeff Marchi was correct. What happened was I reached out to our patient advocacy team at Novartis, and they said, and I gave them a heads up, and they said, have Frank fill out an adverse events form because he relapsed 6 weeks after his final Pluvicto, his 6th Pluvicto, and have his doc fill out the medical doctor's form, and let's see what we can do. I never heard any more until Frank called me and said Novartis have approved another year's worth of Pluvicto for me. So we may have had an impact, we may not have had an impact, but the outcome was a treatment alternative provided by Novartis, with whom we have a very good relationship.
Amen.
To allow Frank to continue. I suspect that there was some impact, and in fact, when I saw the Novartis lady at PCRI, I thanked her. And she's sort of my newer lady. Our older lady was in Dublin with her husband's family. So anyway, and I also thank Rachel Levine. Now, the issue for me is this, and I've told Frank a couple of times, I don't know that it would hurt to wait a little bit whilst you try and find out whether you're a good candidate for the alpha break study. And Ben, I'd really, really like you to comment on that because you've done some really good research on that alpha break study. We know it's available relatively close. I think Omaha is probably the closest. It's fewer treatments, maybe. Ben will tell you it's either 2 or 4. I can't remember without checking it out. But having said that, it's a different type of radiation, and it is still attracted to, I'm pretty sure, I can't remember if it's PSMA. It might be a steep treatment. I think it's PSMA. Again, I just have to remind myself. It's steep. But it's attracted to to a different protein, but there may be a good outcome. So let's start with Ben. What we want to do is give you as much information so that when you talk to your docs at the James this week, you're well informed and you can push them and you can have a meaningful conversation about alpha versus beta in a second go round. Ben, come in.
What could I say that would be helpful?
Just explain the alpha break trial a little bit so that he can use the information and why it might be a good alternative.
I already have that information. You've already emailed me that, so other than waste a lot of other people's time, we have that information, and I'm pretty sure you emailed that to me, Ben, or Rick did, but I have that whole thing about the alpha break, and I read all. Did some my own doctor research, Google, and saw the pros and cons of it. And yeah, so we are going to talk to Dr. Yang about that. I mean, we're also geared up to start Pluvicto on Wednesday, so.
The only thing I'm concerned about is that if alpha break is really viable, and you start the Pluvicto now, there's a period of time that you have to wash the Pluvicto out in that alpha break study, as I recall from reading it. So once you start the Pluvicto, you may not be eligible for the alpha break for a while. And
right. So
you've got to be looking at the two together, Frank.
Yeah, I will definitely talk to the doc about that. I just want to figure out what my best options are. I mean, like I'm healthy as hell. I mean, that's the thing that I don't understand. I mean, I'm losing a lot of weight, but I mean, yeah, I've had all the side effects of the peeing and the incontinence and all. It's no big deal, you know what I mean? It's life, tiredness, fatigue, whatever. I get over it. I just go to work, whatever. But yeah, so I'm a tough guy, and I'm gonna run. I ain't going anywhere. I'm gonna run, but I'm gonna bring that information.
We know that. We love to hear it, but we want to.
Yeah, but my history is that I've been like a tough I did drywall for 40 years. Come on,
Frank, we want to make sure this is the right choice.
I get excited. Yeah.
We want to make sure that this.
Yes.
We want to make sure this is the right choice, that the beta is the right choice rather than the alpha, because you would slip right into the alpha trial. And has anybody want to say something about alpha versus beta? Come on, guys. Some of you more knowledgeable guys.
I'm not sure.
Well, I do believe they've done studies where the alpha following the beta, they have shown some people will respond. So
the alpha is it's like a direct hit. It's like a guided missile. That's how I understand it. Where the Pluvicto is like a bunch of missiles going and grenades going or whatever, and it's going to could hit some good cells, right? And the alpha is just a target, sends the missile and bam. That's how I view it. Is that right?
Alpha is more powerful, but it doesn't penetrate as far as the beta. Beta is weaker, but it penetrates further.
Right.
Ben knows more about this than the rest of us.
Yeah. I mean, that's yeah, okay.
Yeah. Just one last comment for you, Frank. Grace can come to the sinner as well as the saint, so don't beat up yourself.
I'm saved. I gave my life to Christ in 1983, bro.
Oh, there you go.
Yeah. That's all right. Later, bro.
Len, I just want to correct one thing. I think that the alpha is a much narrower target and penetrates further. The beta is a much wider distribution and doesn't penetrate as far. Is that right, Ben?
No, Len was right.
Len was right. Excuse me, as usual. Okay. Repeat it again then, please.
Oh,
Um,
well, go ahead. You do it then.
Apples and bowling balls, Ben.
yeah. The Yeah, the alpha particle is, as John reminds us, it's the difference literally between an apple falling off a table and a bowling ball. It gives up all of its momentum on the first hit. Um, the betas are likely to follow a glancing path and travel quite a ways before they finally come to rest.
But doesn't the alpha penetrate the cancer more deeply and more narrowly, and the beta is sort of splattered around and may not
Uh,
go as deep? Or is that a wrong
no,
way to think about it? Help me, because I need to know here too.
um, no, the alphas are superficial. They're big particles, and when they hit, they stop.
Okay,
Where the others
okay.
can have glancing blows.
All right, Ben, as long as we're on you right now, it's your turn.
You know, it was just an update, and it can go next week without any loss of consequence. So I'll save it for next week.
You're sure? Because Rick will be here till midnight if he has to.
And Ben, you got us on tenterhooks. We want to know what's up with you. Don't make us wait till next week.
It's true. I don't often give updates. Um, so I'm going to really cut this down to the quick. I started ADT in July 2022, and they took a baseline PSMA at that point. And earlier this month, I had another PSMA test. Um, because my PSA had crept up since then. I've been on ADT, as I say, with Nubeqa. Um, the PSA was under control, but it has crept past the 0.2 threshold, and I've gotten my scan. And I'm going to show you rather than talk about it.
Can you tell us what your PSA got to first?
Yeah, um, point, 0.23.
Okay.
So nothing spectacular. So what the PSMA showed, it's interesting. So the lung nodules, there were no new notable nodules except for one, and they all increased about 50% in size. They should not have been, if the treatment were fully effective, they would not have increased in size at all. So they've gotten a little bigger, but nothing new showing up. With the one exception of there's now, I no longer have lung only mets. There's now um, a lesion on my spine, my lower spine, the L3 vertebra. What's interesting though, what's fascinating, is that although they only grew a little, the SUV just whoa, it grew by many multiples. So here's a case where the SUV had been 6.3, and now it's 28.8. Previously, it had been 3.1, and now it's 20. Here's something that was just a little dot before, with an SUV of 1.8, and now it's 3/4 of a centimeter, and the SUV is 8.5. And even this new lesion that just showed up is already SUV 12.6. So these are, when a lesion gets bigger, the SUV shouldn't even change. That should be completely uncorrelated. So the cancer has just become amazingly PSMA avid in these 3 years, and it was just too tempting a target for Dr. Rathkoff to overlook. It was like hanging a big "kick me" sign on the cancer. So I'm going to go on Pluvicto is the answer. I had she gave me a CT scan. She is, neuroendocrine is definitely on her radar because the PSA is so small. It showed nothing new, nothing different. And I'm going to have an FDG scan scheduled because bless them, the nuclear medicine guys won't see me without one. So, assuming they don't find much non-correlation, they will not. They will schedule me for Pluvicto.
But Ben, I have a question for you.
Yeah.
Would you really have gone forward even without doing an FDG PET? Notwithstanding you look so much more avid, wouldn't you have insisted on an FDG PET?
It's interesting. I don't know why. I didn't explore with him why she did a CT rather than an FDG. Her objective was the same. She was looking for non-active lesions. Maybe just because I had forgotten what a pain in the ass a PET scan is. You put your arms over your head and you think, oh, I could do this forever. And at the end of the 40 minutes, you feel like you've been captured by the Taliban. Maybe she just didn't want to do 2 of those in one shot. But I will be getting it.
All right.
Well,
All right.
I'm glad to hear that they're thinking about the FDG PET for concordance. Not too many doctors seem to be doing that, and I think they should.
Yeah.
No.
The nuclear medicine department is on it.
I know.
Such as it is, they have way too few nuclear medicine doctors, like all the rest of the medical profession, all the rest of the hospitals in the country.
Can you stop sharing when you have a moment,
Oh,
please,
yeah.
Mr. N? So one of these things I want to point out is that, Ben, you're doing this before docetaxel based on the new approval, correct?
Oh, am I lucky? Yeah.
Yeah.
Yep.
Yeah, that was the PSMA 4 trial?
Oh, that sounds right.
Yeah.
Ben, are you resistant or are you sensitive to hormones?
Well, that's it. It's changing now. I was sensitive, but my PSA is going up.
Not so quickly, because you were at 0.22 in June, and now you're at 0.23 in September.
Yes, not at all. But the lesions are getting bigger.
But the lesions make it worthwhile. I want to address something that the Fairbanks put in the chat window. First of all, we don't see any value to the choline scan, even though Dr. Kwan does. That was reiterated at PCRI by Tanya Dorf, who's one of the best GU medical oncologists. Somebody actually asked her, Dr. Dorf, what about the choline scan that Kwan does? And she very diplomatically said that the PSMA is a much superior scan, and the choline is unlikely to show anything, which is what we've always said, but it was good to hear it from somebody as reputable as Tanya Dorf.
Choline is like a punchline. It's just
yeah. I mean, Kwan. I don't want to reiterate, but you're spinning your wheels and wasting your time, and I would just drop him like a hot potato if it were me. But if you want to keep seeing him, but just bring his advice back to us, or take his advice to Dr. Heath. But he doesn't need to do a choline PET scan now. The issue of the CT scan of the lungs versus another PSMA PET. What we're talking about here, the reason we're doing the scans that Dr. Rathkopf did, the CT scan, and now they want to do an FDG PET, is because we want to make sure that there's nothing that doesn't express PSMA. People forget all the time that about 18% of men do not make PSMA. I mean, it just astounds me how people go, oh, PSMA, you've got to get a PSMA. I just sent a reply to the AUA because they're recommending PSMA. Not once do they say, what about the men who don't make PSMA? It's 1 in 5. It's no small percentage. And I wrote back to the PSMA on behalf of AnCan and said, you need to put something in here for all those men who don't make PSMA. So there are 2 reasons to do these other scans. One is to just make sure that the PSMA picked up everything. And the other is that if the PSMA, if the PET scans, the FDG PET is showing a different result to the PSMA PET, then you got to have a serious conversation about what's the right treatment. Pluvicto might not be the right treatment for somebody like that. So those are the reasons. I mean, the lung mets that you're looking at, Diane, is we think a prostate. But if those lung mets do not, that's what they've told you so far anyway. If those lung mets do not show up on the PSMA scan, it's going to change the way Dr. Heath will treat you. So hopefully that explains it. And I took the time to mention it because it's important to everybody on this call. Just, if you're PSMA negative, it doesn't mean you don't have something going on. You've got to talk to your doc about what else can we do to verify. Start with a PSMA, but if it shows nothing, you got to verify with something else. Right, Dr. Jack?
I mean, it depends on what the PSA. If my PSA is 0 and I get whether we follow with an FGG or PSMA scan, I don't know. I just don't know. I don't know what's right and what's wrong with what kind of scan to get to follow me right now.
Well, you didn't show anything for years and years and years, and you looked at all those other scans too, and they didn't show anything either. And then finally you showed something on that PSMA, right?
That's correct. When my PSA biochemically reoccurrence went up to 1.8 or something like that.
And Dan Hyatt has had his hand. Donald Hyatt's had his hand up for a while. Go ahead, Donald.
Rick, may I interrupt? I have to get to Manhattan early tomorrow morning, so I'm going to take you up on your offer and drop off and let you take over, okay?
Thank you as always, Len.
Okay, thank you.
Show of
Thank you,
hands,
everybody.
show of hands for Len.
Thank you. Okay, guys. Good night.
Donald Hyatt, please go
Yeah,
ahead.
I can't get my camera to work, but I think my microphone's working.
Yes, it is.
So in 2015, I was diagnosed with prostate cancer and went through a radical.
Hold on. You have your hand up. Is that because you want to say something about what we're talking about, or you want to give us your history?
One of the things that the history as it's progressed, I've had 5 Pluvicto or lutetium treatments, 2 in Australia, 3 in Canada, and was getting ready to go back for a round of them here. They did a PSMA scan. And
I don't want to, Donald, I don't want to talk about your own history right now because we can only take newbies in the first 10 minutes. And as you see, we're running late. You are very, very welcome to come back next week. Ben will be leading. We'll take you as a priority newbie. We cannot get into new people right now. If you have a comment on the discussion for Frank Chambra or anybody else, we're happy to take it. But
the comment is that PSMA scan, I no longer express PSMA and am not a candidate for Pluvicto anymore.
Okay. So then we would say to you,
my PSA is 95.
Okay, look into the Alpha Break trial. Alpha Break works with sleep.
No, John was wrong. John was wrong. Alpha Break is a PSMA treatment.
Oh, Alpha Break is. I thought it was. Yeah. Okay. Are they doing a radioactive trial with STEEP, Ben?
That was the bispecific, but
Oh, there's a bispecific, I know. But
right.
yeah,
Well,
AMG,
I don't. Yeah, I don't know if they're doing anything else with steep.
yeah, AMG 509 is a steep trial. Can't remember the name of the trial, but you know, if you drop us a line, Ben or myself, RD at AnCan.org or Ben at AnCan.org, we can tell you about that trial. But we'd love to talk to you about your whole history. It's real interesting. But for people who need time in the meetings, we have a rule because, as you see, we have so much. You've got to be here in the first 10 minutes. Sorry, Donald, but we're happy to support you and help you any way we can.
Before I bow out, I have, I think, a really interesting fact about PSMAs. We're always trying to figure what's the right PSA for PSMA PET, and I'm in the position to have had 3 PSMA scans at the same PSA. I had one right after my recurrence after surgery. My PSA was 0.22. I had one after my recurrence after salvage, and my PSA was 0.22. And I had one just the other day, and my PSA was 0.23, and they showed very different things. The first one showed nothing. The second one indicated indicated the lung mets, and now the third one is indicating larger mets, but an extremely a major change in PSMA avidity. So there is no single answer. There is no single equation from PSA to PSMA avidity. I can attest to that firsthand.
For you.
Well, I mean, this is a point that we keep on making, that when you get the PSMA scan, there's a point that you keep making, that when you get the PSMA scan is has a bearing on what you'll see, you know, independent of PSA.
Well, yes, but what I would say is it's true for most people, but it may not be true for everybody. So what I'm saying is you may be an exception because most people, they do see a difference. I'm not saying you're wrong at all. I'm just saying that's not a rule of thumb for everybody.
I'm saying you can't rule it out. You can't say it's too low or it's, however.
You're right. You can't say it's too low. You can't, you cannot. But for most people, we know what's too low because they've done the studies. For some people, it just doesn't work. It's like, it's the same, you know, prostate cancer is so individual and everybody's so different. But we have to have some basic rules. Otherwise, if we didn't, we'd be saying, okay, you've got a 0.009. Let's do a PSMA scan.
Okay, I'm hanging on by a thread here, Rick. Let's move on to that rest of
Okay, I'm fine, Ben. But what I don't know is who still. Len didn't send me a list of who we still had to get to. So if you still need time, please put your hand up and we'll get to you. Okay, Larry. Oh, Larry Fish was going. That was a goodbye. Oh, Jim, please use the hands up function, guys. Just use the hands up function, and then that will help me. Jim Kavanaugh. Okay, you need time.
Yes, just real quickly, I'm looking for any information.
Hold on. Is there any, let me just see who needs time so we can figure out. Is there anybody other than Jim Kavanaugh who needs time tonight? I'm happy to stay. I'm happy to give you the time. And Donald Hyatt, if you want to do an intro, a complete intro at the end of this session, I'm also happy to do it with you, which is usually what we do if people come in late. I'm happy to take your input, or you can wait for a full session next week. All right, so let's go to Jim, and then that will clean us up for those people from the beginning. So go ahead, Jim.
Thanks. I'm looking for any direction that I can get. I'm looking for information on gaining testosterone back. I'm down to 0.7. I have no basis of history. saying what it would have been before. I was hospitalized last week for failure to thrive. Last night I was taken off of, I had bleeding in my right ear, and they've removed the sleep apnea equipment until further notice. And I fell before getting on today. I just feel weak. I have no energy whatsoever. So it's really at a stage they're going to try and bring in some help and so forth. But in the meanwhile, the fact that Orgovyx did a great job in bringing me down to undetectable cancer is great. But the flip side is that I have no testosterone, no energy. I know I've heard different people mention low testosterone. My fatigue is incredible. I'm just a plea for help. Any information, any guidance.
Ben, do you want to kick that one off?
Have your doctors talked about this as a possibility?
I have another call in to my radiation oncologist and another call in to my urologist. Both of them were waiting for things to happen 3 months from now. I don't have that type of time.
I mean, it's not clear that this is going to be your golden bullet. I think this is a syndrome, a variety of things that are contributing to the cause. But I'm going to turn it back to Rick.
Yeah, I mean, you're showing no sign of metastasis anywhere. That's correct? When was the last time they did a PSMA scan?
That would have been months ago. At that time, there was no metastasis.
Well, the first thing I think you have to establish, because they've taken you off the Orgovyx, is you have to establish that they are as comfortable as they can be that you're not metastatic. And you have to do that with your radiation oncologist, your urological oncologist, and I will write again to Chuck and see if I can get him to see you. He didn't respond to me last time, which is unusual because he usually does, but it sometimes takes him a while. Failing that, we can take a run at trying to get you into somebody on Second Avenue.
Okay.
I might ask Ben to drop a line to Dr. Rathkopf and see if she'll see you to try and help you figure this one out, especially since we're taking you off the Orgovyx early. But, you went on the Orgovyx, remind me, because there was a recurrence. Isn't that right?
Yeah, I initially was on it January 3rd before radiation. Radiation ended February 28th, and I came off of the Orgovyx 19 days ago.
And they gave you the Orgovyx along with the radiation, correct?
They started me before the radiation, January 3rd. Radiation was 2 weeks at the end of February. They thought it would give a bump up.
Okay, well, the bump takes a while. So the bump isn't like as soon as you finish. But, we've got issues here. I mean, to me, your whole history shouts that there's something else going on and we can't figure out what it is. And it may have nothing at all to do with prostate cancer. Have you seen an endocrinologist?
No.
Okay. So I do think you need to see an endocrinologist. I do think that you need to get an all clear from your prostate cancer team now, not in 3 months, that they don't see any metastasis right now. Doesn't mean you're cancer free, but they don't see any metastasis. Because before you start supplementing with testosterone, you've got to be comfortable you don't have cancer in your body.
Got it.
All right?
Yes.
You can't just, you're not the same as somebody who's never had prostate cancer. The testosterone has a much higher risk to you if you have prostate cancer than somebody who never had prostate cancer.
Got it.
Okay, so you got to get a sign off to me there, and that's what I will be trying to get. If you need us to help you get an appointment with a GU medonc, which I don't think would hurt, we can do that with a couple that we know. But you've got to be sure. Then the question is, do you supplement? And that's really something you've got to talk with the endocrinologist about. That's how I would go about it.
Okay.
Who else has any suggestions? Especially, we got Dr. Russ still on, who's, had to deal with similar issues and recurrence and low testosterone. He's a contemporary in age. Dr. Russ, how would you approach this problem with Jim Cavanaugh?
No, I'm not sure I can answer that question since I'm more surgically oriented, but I feel like you do, Rick. There's got to be something else going on. And, you sent me this promotion about activin and sarcopenia, and I mean, he's losing weight, and I mean, he really is in metabolic trouble. And I think you're right. An endocrinologist would be somebody that I would recommend that he see. Something is not right here. I mean, we're talking about somebody's almost ready for some intravenous hydration here and supplements. Like, how much weight has he lost? How much weight have you lost, Jim?
I was down to I had, my normal weight is 131, down to 122.4. I've been eating like crazy. I gained 4 pounds in the last 2.5 days, just trying to put on weight.
I'm sorry, I don't have any other suggestions.
Yeah. I mean, I do suggest you meet with a nutritionist, provided by whoever your medical team is.
Yes, I have met with a nutritionist, and they said I'm eating a lot of protein. I need more calories, just eat as much as I can. So that's what I've been doing. I'll follow up and try and get an endocrinologist. I pushed both of my doctors, and I will do that again tomorrow, because I understand your information that I need guidance to just confirm that I don't have something metastasizing. And I am open to going to New York if we can do something there, but maybe we need these first answers first.
I would think so. Ben, what would you say?
How about a palliative care doctor?
Good idea. Yeah, to get it, try and get a palliative care doctor on your team. Palliative care means symptom management, not end of life. So, maybe a palliative care doc, when you tell them your history, is going to have an idea who to send you to.
Okay.
I think that's a great suggestion on Ben's part, and they should be able to refer you to a palliative care doctor in the area of New Jersey where you are.
Okay.
But we're casting around to try and get you the right referral. And I do want to say to you and everybody else on the call, the earlier you get to this call here, the earlier you get to this call, the sooner we get you in the group. When you come in late, Len's taking the call, your name is further down the list. So you guys who come in at 10 after 5 just to make the call, we're going to talk to you at the end. The guys who get in here at 10 before 5, they're going to get up. They're going to get up first, and your discussion needs longer. And Jim, you always come in fairly late, and so that's why we get to you late.
Got it.
Last week too. Okay, we're not willing to talk to you, but we try to take people in the order they get it. And if you get here after 10 after the hour, we don't ask you if you need time. We don't see you as a newbie, only if we have time at the end. Because when you got 40, 45 guys, there's got to be some order. We can't just have people come in and get priority. And I'm sorry, Donald, and we'll definitely take you as a priority next week.
Understood. Each of the suggestions I'll follow up. They're helpful. Thank you.
Okay. And I just don't know. I'd like to have had Dr. Jack and Dr. John on the call when we were talking about this. Because they're the people that are, their experience is medical. They may not be in the right field, but they know enough, especially from the years when they were trained, when they had to be more generalists as well as being specialists. So that's what I'm saying. But please. Oh, we got Dr. Marty. I haven't even asked you once yet. Oh my gosh, that's because I'm not used to you being here. I completely forgot you were in the room. Dr. Marty, what would you suggest?
Well, I definitely would do a workup. There's so many causes for fatigue and, sleep difficulties, depression, thyroid problems, anemia, et cetera, et cetera. So did a good general workup. And you also discuss the option going testosterone if everything's negative. Other thing is, besides palliative care, is exercise is good. But I'd recommend an exercise program. That's probably the best thing we have to offer for fatigue right now.
Yes, and I was doing doctor exercises, PT, and they hit the glutes, and I reached a 9 in the butt, and I basically couldn't do anything for the last 3 weeks, unfortunately. So I was on it for 3 weeks to try and get muscle strength. So you're right.
Maybe you just just cut back until you're not in significant pain. You can consider pole therapy, which be less aggressive.
Great idea.
Pole therapy.
Great idea for pool therapy. Call the Y or one of the gyms around and see who's got some pool aerobics classes, because it's going to be much easier for you.
And you said you live in New Jersey?
Yes.
Northern New Jersey? I mean, there's
Morristown, New Jersey.
Yeah. I don't know New Jersey too well, but Kessler, which is Northern New Jersey, has a huge cancer rehab program with therapists. You could check with them as an option.
Where was it, sir?
Kessler.
Can you spell it?
E
Rehab. And they have satellites all over the area.
Is it CASPER? I'm sorry.
CAESSLER.
Okay.
CAESSLER. Kessler.
KESSLER.
Kessler. Got it. Kessler. We got it now. And Dr. Marty, please excuse me. I thought, oh my gosh, Dr. Marty's here at the beginning. And then I completely forgot we had you in the room where we would have been asking for your advice earlier on. My bad and Len's bad. And we're very sorry. Come back. Don't be a stranger. That's what happens when you're a stranger, Marty.
Well, you were doing a great job. The whole group was doing a great job. I didn't have much to add.
Oh, we would have found something when it came to muscles and neurology and some of that stuff and rehab. We would have found a way to get you in, believe me.
Thank you, Marty and each.
Thank you very much. Just for those of you who are here and on the recording, Dr. Marty Weiss, who's on our Brains Trust, was one of the first ever physiatrists, long before anybody even knew what a physiatrist was. Is that correct, Dr. Marty?
Well, I'm not the first, but my number is like 9,800. So there's a lot more since then. I graduated in formal training in 1983.
Okay. Well, thank you. All right. I we're exhausted with the advice we can give you, Jim.
Thank you.
I think get through these first steps. If we still think you need to see a GU med-onc, but frankly, if you are free of cancer, you don't really need the GU med-onc. You need somebody else, and that's why we're sort of moving you around.
Okay. I'll follow up with these. Thank you very much.
All right, guys, and thanks for everybody, all 16 of you who hung in to the bitter end. And Donald Hyatt, please come back next week. In order to get in to get a newbie time, you've got to be here in the first 10 minutes. Next week's meeting is at 6 o'clock Eastern on Tuesday the 23rd, not 8 o'clock. So try and get in here in time. Ben is here this week. He's going to be leading next week, so he knows who wants to come back. We got to give some time to Henry, hopefully next week, because everybody wants to hear about the what's it called, that therapy aptitude. What's it called?
Adaptive
aptitude.
You know, Rick, you taught me so much, and now you've taught me how to be a smart aleck too, and not remember anything.
God bless you, Henry. So, so next week we've got a few returnees who gave up time this week, and Jim, Joe Kamada, Joe Commander, and you know who they are, right, Mr. N?
I will make it my mission to see that they get time.
Thank you very much. Thank you very much. Okay, guys, I will say good night, and we'll see you next Tuesday. Good night from Len. Good night from me, Dr. John and Ben, and everybody else.
Good night.
Good night. Good night.
Good night. God bless.